All right. Hi, Colette.
Hey, hey.
Hey. So this is our first interview that we're both posting on our YouTube channels. And just for the viewer, Colette and I, we've been in touch about sleep disordered breathing generally and went through computational fluid dynamics of Colette's case. And yeah, we just kind of got into brainstorming about different topics and both found, that we shared similar interests. And we brainstormed and put together a list of topics that we'd like to discuss. And one of them was arousal thresholds, because we felt like that is just a whole box of worms that kind of encompasses everything that or at least I'm speaking from my experience, it's at least encompasses a lot of like what I am struggling with UARS, and also explains a lot in terms of what I'm experiencing in my everyday life with UARS in terms of symptoms and treatment and just how I get through the day. Yeah, and I'd be curious to hear from you, Colette, why this topic is so interesting to you. And I think the viewer will also be super interested to hear about it, and also some of your ongoing work on trying to reform like the AASM and how things are going on that front. But also about your treatment and maybe background. Maybe Colette, do you want to like just introduce us to yourself and where you're coming from and you're interested in the topic?
Sure. Yeah. Yeah. I'm super interested in this topic too, as someone with UARS. And I feel like one of the hallmarks that people think of UARS that differentiates it from sleep apnea is arousal threshold. And it's probably, in my opinion, like one of the most controversial things about UARS. But yeah, I've had sleep issues my whole life. So I had pediatric sleep apnea at like age 4, and my parents could hear me snoring as a 4-year-old, which wasn't normal. And so I went and I had a tonsillectomy, and the doctor just said, "All right, she's good. Like it's a done deal," and sent me off into the world. And then, slowly over time, I started getting more and more tired because it didn't resolve the issues. And I'd say things started to snowball for me around like 14 or 15. I think that's when a lot of people really just like start to hit problems. Like you go through puberty and your airway like dynamics change, and then it just kept getting worse and worse. And so I've been through the gambit with sleep studies, and my very first sleep study, like they found an AHI 15, and told me that it probably wasn't the source of all my fatigue. And so I've had a couple of sleep studies, and that's how I stumbled across UARS, because I've been diagnosed with chronic fatigue, and then I've been diagnosed with depression and all these things. And then I just kind of realized after doing more work into it that it's UARS is my problem. And so I've done expansion now with FME. I've done 6 millimeters of expansion, and I've had a turbinate reduction, and I've tried CPAP, BiPAP, ASV. But and then this past year, I got empty nose syndrome, which was probably definitely the worst thing that's happened to me, despite all of my UARS issues. And so, yeah, I've just been really interested in sleep disordered breathing in this space. And I think that the AASM has come a long way since, the 70s or the 80s when they started, but they have a long way to go. And we have a whole patient group that's being like systematically left out by their scoring standards. And so I'm in the process of writing an open letter to their board of to the patient board and to their scoring committee. And I'm working with a friend who also has UARS to make a patient support website, which I hope will be up in the next month or so.
Okay.
Yeah. So both of those things we've been working on for a while now, but it's just finally starting. And so we'll get the ball rolling on that. And yeah, but I'm super interested in arousal thresholds, and I have a lot of opinions and hot takes, or maybe they're hot, maybe they're not, but yeah.
Yeah. Well, shoot, there's like 100 topics that we could jump in that you already touched on. But I guess in the interest of just staying on topic and not branching out too much, in terms of the arousal threshold, what do you think, how does it relate to UARS? And are there things that, you're writing in your letter now towards AASM? I assume there's like a lot of overlap probably in terms of what you're trying or you're advocating for in terms of changes and, what UARS is versus how they define it or what they're looking for, in terms of diagnosing it and so on.
Yeah, I mean, that's a good question. So, I mean, UARS is so controversial in the world of sleep medicine right now. It's not even really recognized. It's in the ICSD-3, I think, like once. Like literally the term upper airway resistance syndrome is in there just once, and it's classified under mild sleep apnea. So for my letter, I kind of stayed away from talking about it as a separate entity, and I'm going to let them do what they want to do with that. But I was really focused on, like, there's a group of patients, whatever you want to call them, that are left out right now. And their symptoms are just as severe, if not more severe, but they're getting missed. So whatever you want to call them. And like the term came up inevitably. Like I didn't stay away from using it at all. But I definitely did just focus on, like, let's change the scoring standards, and you guys can like call it what you guys want to call it, even though,
Sure.
It's established. So yeah.
Right. Yeah. The way I can conceive of it is like, well, it's kind of difficult to get through all the different ways you can kind of, I guess, categorize OSA versus UARS. But right, so as of right now, you're saying, they're categorizing UARS as a subcategory of OSA. It's kind of like they're saying it's along a spectrum. And I've read multiple times that, that at least doctors are misled into thinking that UARS is kind of like a subtler, maybe less severe form of OSA, whereas, like you're saying, people with UARS often have worse symptoms. They feel worse, they're doing worse, and they're less served by the doctors because, the categories aren't clear and the definitions aren't clear in how to capture UARS or and treat it. Is that about right? Kind of the way I described it, or?
Yeah, that's spot on. I mean, we're just like different than most of these doctors have seen. Like when you think of like the classic sleep apnea patient, I don't know about you, but I think of like an older, maybe overweight guy who's got a higher BMI, he's got a thicker neck circumference, he snores, but he's like tired, but he's pushing through, and maybe he doesn't really feel like he needs CPAP, but he gives it a try. But then we are, as a patient group, much younger. Almost all of us are like pretty thin, and a lot of us deal with, instead of like high blood pressure, we're dealing with low blood pressure and like insulin resistance and low blood sugar and like crippling fatigue, where we know that something's wrong and we've known it for a while usually. And I feel like as a patient group, we're going into these clinics and the doctor's like, well, you're young, you're thin, you're in good shape, you should be fine. Like, why don't you check out like the psychiatry department and see what's going on? But like, it's just because our oxygen doesn't dip low enough for us to get caught by the PSG standards, but we are suffocating in our sleep. Like, suffocating a little is still suffocating. So it's, you know, it's just a matter of like when they're going to change their standards so that we can get included. And all the people that are getting missed right now who don't realize that it is UARS and go on to take stimulants for ADHD or whatnot, like they're not getting served by the community.
Right. And you could argue the opposite in a lot of the cases. But backing up one step, like, yeah, I read a bit on Christian Guillemot, I guess the guy who kind of termed or coined UARS. I forget when it was, but yeah, I'm sure you've heard of him. And he did a bunch of interesting studies, where he found exactly what you were saying. Like the patient groups were like in their 30s, younger, more often than not women, and skinny. And right, he said also low blood pressure versus a higher blood pressure and other symptoms, which just don't line up with OSA. And he was saying, and what I liked about his definition is kind of what defines UARS versus OSA is an overreactive nervous system or a high sympathetic tone versus an OSA, a lower sympathetic tone. So essentially what happens then, and it lines up with what happens with people with obstructive apnea versus us, people with obstructive apnea, they'll just be snoring through the entire obstruction, not noticing it, sleeping seemingly fine. The people next door want to go and wake them up because they're being so loud, and their brains aren't like figuring out, hey, I'm actually suffocating here, and their oxygen levels drop and drop and drop, and that's what causes their symptoms, is the oxygen drops. It's not the constant stage shifts out of different stages of sleep into lighter, it's not the sleep fragmentation as much, but then we're on the opposite side where our nervous systems are so in tune and what do you call it? I guess reactive to even smaller limitations, flow limitations, we can call them, right? The smaller obstructions in our airways that we immediately kind of wake up when there's an obstruction or we get less air, and our sleep is completely messed up, and we wake up. I was waking up 50 times an hour. In another study, it went up to 70 times. So it was just, I guess the sleep technician was very,
more than every minute. That's awful.
Very precise. Yeah. Yeah. Exactly. Right.
Oh.
Yeah.
Yeah. I mean, all of that I would mostly agree with. I think it gets complicated when you get into like, okay, so like, yeah, I can agree with we have higher sympathetic tone than like your traditional OSA patient, but then it gets into the, the question is a higher sympathetic tone, does that mean that we're overreactive, or are we actually right where we should be? And are those patients underreactive? Like, why aren't they waking up? Like, why would your oxygen dip when you're suffocating in your sleep? Wouldn't your brain like want to wake you up immediately? And so I almost think that like our arousal system, like our nervous system causing arousals, that's almost more adaptive than it is maladaptive, like in my opinion. But the other thing we have to think about is like, it's not just two nervous systems that we're comparing like two phenotypes. So I feel like the UARS phenotype is a structurally more narrow airway to begin with, and we're younger, so we probably have a little bit more muscle tone to keep that open longer for, compensating for it. But whereas someone with OSA might have like a bigger airway that's just floppier, and so like they can afford to snore. I don't know how to explain it other than like they can snore and have those vibrations in their airway, whereas if we even snore a little bit, it's going to just like the negative pressure is just going to like it closed, where it's almost like we have less room to collapse, where even just like the same flow limitation for us versus for them it's like a normal flex of their airway. And for us, like if we're starting with this, then we get like a 5% decrease.
Yeah. That's an interesting theory. Yeah. And you mentioned phenotype, and that reminds me of actually, and this is pretty interesting work, and I wonder why, probably doctors just aren't so well versed or something. I just haven't heard of this very much, but there being different endotypes, what they call them, of obstructive sleep apnea, because that's apparently mostly what's studied, not UARS, but they're saying one is arousal thresholds, having a low arousal threshold that characterizes your OSA or UARS. So that being the cause of your waking up a lot. Two, the thing that you just mentioned, which is poor muscle recruitment in the airway. So you can apparently have an obstructive apnea, but not wake up, and your body still recruit the airway muscles to open up the airway enough to breathe again. And this happens in the deeper stages of sleep, if you can get there. So with UARS, oftentimes because we respond immediately to any airflow limitation, we're stuck in N1 sleep or N2 and never get to like really deeper sleep, and especially not REM. So our brains never get to this point where they can activate the muscles and dilate the airway. That's two, or people with Elon, what is it called? Ehlers-Danlos?
Yeah.
The syndrome where your muscles are quite lax.
Yes, that's a huge comorbidity with sleep apnea and with UARS for sure. Yeah.
And then the other phenotype was, what was it called? Right, having a high loop gain and chemosensitivity. So high sensitivity to CO2, and then overreaction to under or over breathing, where you start hyperventilating or underventilating, under breathing, which causes this instability in your breathing. So that was like the three that I had found. But yeah, and then arousal threshold being one of them. And I guess that's the most relevant one for us.
Yeah, I mean, those are all really good points. Hold on one second. There we go. Okay. Yeah, I mean, it's a really good point that there are lots of different phenotypes or endotypes or symptoms even. And I do wonder about like the loop gain and the CO2. Like if you've got a very small airway and then it partially closes, you're getting less gas exchange. So you might be under breathing or hypoventilating, and you might get like a buildup of CO2. And then that might like get worse and worse until you have to kind of have a partial arousal, and you have this big like sigh breath thing to expel all the CO2. And now your CO2 is super low and you don't need to breathe for a while, and it just causes this like periodic breathing. Like that is definitely something that could happen. Yeah, I'm trying to remember what the other phenotypes were that you said, but yeah.
Yeah, on the chemosensitivity one, I have an experience to share there. It's kind of interesting. I was trying the BiPAP for a while, right? But then I realized I was because they're saying, pressure support, and this is what Barry Krakow was saying as well. I'm sure like pressure support is where it's at. That's going to help us a lot. It's like we need a little bit of ventilation support to get over the UARS, the flow limitations. So I gave it a shot, and I thought it was helping, but then I was getting periodic breathing. So that's where, exactly like you were saying, you're having too little CO2 in your blood, I guess, and then you started hyperventilating, and it's just knocking your normal breathing rhythm out of whack, and then that's waking you up, essentially.
Yeah.
And to combat that, I started taking Diamox, which is what people take when they, for instance, when they climb mountains, when they go up to really high altitudes.
Is this acetazolamide, but like brand name?
Yes, that one, acetazolamide.
Okay, cool.
Of
Yeah.
course, you know the actual ingredient.
Yeah, I guess so. Yeah.
Active ingredient, yeah. Yeah.
How did you find out about that? Did you just do some research and get your hands on it, or?
Yeah, this was in the day before ChatGPT, and I was just looking through the journal articles and seeing what would help with with chemosensitivity, and I was seeing how to dull that essentially. And I got a doctor to prescribe it to me. I told them it was for glaucoma. It makes no sense. I don't have glaucoma. They're like, yeah, sure, okay. But it was, but essentially what it's supposed to do is increase your blood acidity levels. So decreasing your pH levels, which then makes your brain think, oh, I need to breathe more to lower that pH level again. So it increases your ventilation respiratory rate. And the idea is it stabilizes it. And sure enough, there's actually like a new medication that's out, Solthium or something, and it's like in clinical trials.
Yes.
For OSA, and it's supposed to decrease the breathing pauses by 47%, whatever that means. I doubt it would work with UARS, but maybe it's promising with OSA. I wonder.
Interesting. So did you see any improvements with the acetazolamide?
No, opposite. It was worse, way worse. And I would guess it's because it increased my respiratory rate, which just means I'm just making my body experience more flow limitations per minute. It's not like.
That's super interesting. I mean, I think acetazolamide is supposed to help with like treatment emergent central sleep apnea. Maybe I can't really exactly remember how it works or what the mechanism is, but like maybe it was decreasing your sensitivity and you needed more sensitivity. I don't know exactly, but yeah.
Decrease the sensitivity. Yeah, to
Well, there's
CO2.
something else out there that is actually, I think it was invented by Dr. Robert Thomas, if you've heard of him. And it's called EERS. I've got to look it up to remember what it stands for. But essentially, it's enhanced expiratory rebreathing space. So it basically increases the amount of carbon dioxide that you're breathing back in. So you're rebreathing the air that you breathe out. And it's super useful for just boosting that CO2 and helping with periodic breathing and centrals and stuff. So I would totally shot if you can get your hands on some tubing.
Yeah. On some tubing, yeah. Go to the. Yeah,
I don't know who sells it. I'm sure it's available on somebody's site. So.
Right. Well, I don't use a BiPAP anymore because I can't really tolerate the pressures anyways, to where I can get like a meaningful pressure support. So yeah, I can't use it. But yeah, I wanted to tell you about the Diamox thing. Because I thought that was interesting. But it's kind of like also along the lines of any kind of other drug, like the Z drugs, like Zolpidem, other kind of tranquilizers essentially that are supposed to help. And I guess the idea behind them is they decrease your arousal threshold. So helping you sleep through.
Decrease your arousal threshold. I bet benzos would work even better, but you probably don't want to be on those for too long. But
right. No, it's kind of a double-edged sword, right? Like there seems to be no real effective drug because if we assume that URS, we have kind of let's say an active nervous system at least that is waking us up in these because of these flow limitations. presumably if we were to like calm our nervous system, it would help. But by doing that, it's like UARS is just so vexing because like we're so tired the next day or exhausted that taking something that has effects into the next day, like a a sedative or whatever, or Zolpidem, the Lunestas or whatever, and then the next day you'll feel even more exhausted or tired. It just doesn't seem very helpful.
Yeah, I mean, I think that our arousal threshold is so low for a reason, because we've got to keep our airway open the whole night. And so if we artificially increase that, well, what's going to happen? Like, well, we're going to have more airway collapse. We might actually desat for the first time, like traditional, but like I don't know that I believe that sedatives are the answer to make things better, just because you're trading one problem in for another, right? Like, well, now you're not waking up as much anymore, maybe, but like your sleep quality is going to be worse. Your breathing is going to be worse. So.
Right.
Yeah.
I'd almost trade in some desats for just sleeping through a bit more,
Yeah.
No.
Maybe, but you still have to arouse at the end of that, right? Like your body is just less sensitive, I guess, to it. But eventually the alarm bells are going to start ringing in your brain when your oxygen dips. And then maybe it would help like for a night or two. But I just wonder, I just feel like it's all about the airway that you're working with. And if you can open up the airway, your body wouldn't have to work so hard,
Right. Yeah. Yeah, I feel like there's two knobs there. It's like one is your airway and how one factor, that's really important, is just your airway and how the airflow flows through it. And the other is your nervous system and how your nervous system reacts to that airflow. And, you dial, and they interact with each other, those two kind of factors. So you dial the airway to really bad, really thin. But if you were to dial, let's say your nervous system is just really chill, you dial that chill factor all the way up.
Right.
Then maybe you'll just sleep right through it. And maybe you'll get some desats. But that's the only way I can like explain in my mind how some people, they might have, pretty recessed jaws and a tiny airway and still seem to be living just fine and don't have symptoms. Whereas other people, and I put myself in that category, have a pretty decent airway. There's some constrictions, but I think there's a nervous system component to it. And I do kind of lump myself into this category of slightly neurotic, slightly over-worried people that, it seems to line up that maybe my nervous system is a bit overreactive and just in general.
But like, don't you think that those two dials are not independent, and that if you dial your airway all the way up so it's super small, your nervous system has no choice but to be dialed all the way up to keep it open? Like, why would your nervous system be dialed all the way down? Then you'd die. Like, you would never wake up when you like.
Yeah.
I feel you on the anxiety part. I'm also super anxious, and like, I think that's a product of what our bodies have to go through every night to keep us alive and breathing. So I do see I see where you're coming from with, like, I feel like there's a benefit to just dialing everything down. If there's a way you can just force your nervous system to take a chill pill for a day. And I think that might be a good break for your body and for your brain. But I think ultimately, the way I see it is you have to let it do its thing. Like, if this is the airway that you're working with, let it keep you alive and let it keep you breathing,
Yeah. I always come back to this study also that found that, some outrageous number, 60, 70% of people with PTSD also have like sleep disordered breathing, and OSA, and we don't know the directionality of it. Like maybe having sleep disordered breathing makes you less likely to be able to like process traumatic events and therefore develop something more severe like PTSD, or if it could be the other way around as well. And I suspect there's both going on, but I think it has been shown that people who do develop PTSD and didn't have sleep disordered breathing before did develop SDB after developing PTSD, i.e. showing, or I guess kind of hinting at that maybe the nervous system plays a big role as well, because the airways didn't change, but their nervous systems did after being exposed to a traumatic event, which then maybe dialed up that first knob of the nervous system to just interpret any kind of internal or external stimulus as threatening. And them up.
That's a really interesting thought. I mean, I know that sleep disordered breathing causes CPTSD or like complex PTSD, where we never get to rest and restore and process the bad things that happen to us or the negative emotions if we're not getting enough REM and deep sleep. And so I wonder if sleep disordered breathing could predispose us to PTSD, because I know that they've done studies where two people can go through the same traumatic event, like two people in a car crash, and one person walks away with injuries but is otherwise okay, and the other person is scared to drive for the rest of their life. And it's like, well, it was exact same car crash, and like they had the exact same injuries. Like, what is the difference between those two people? I don't know.
So, right. Could be the person who developed PTSD wasn't sleeping as well and wasn't able to.
Maybe.
Could legitimately be. It sounds almost silly, but
I don't think it sounds silly. I don't think that sounds silly at all.
Especially, I don't think it does either. Especially if you think like that SDB is so underdiagnosed, and every second person could probably have it. Like, it feels like that, anyways.
Especially with the current scoring standards. Like, I think about all the people out there who have ADHD or anxiety or depression, and maybe even haven't even gotten a sleep study, but low grade, poor sleep, maybe it's like slight airway problem or something else going on. So
right. I know I was in that category, being treated for everything but the sleep, and that's so frustrating because you're not going to move from where you are unless you address the sleep. I guess you've had similar experience, though.
I mean, I went to Mayo Clinic for like my 4th sleep study or something crazy like that. And I just thought, okay, once and for all, I'm going to go to a really good clinic and sleep lab and get the answers that I need. And then I went in there and I slept for maybe like 3 or 4 hours. I didn't have a good night of sleep. I met with the sleep doctor the next morning, and he's like, so we use the Medicare 1B criteria, just so you know, that's a 4% drop in oxygen. And you never have any of those, so you're good to go. You don't have any sleep disordered breathing. And I was too tired to drive myself home. And I was 19 years old at the time. And I was like, what are you doing? Scoring me with Medicare standards that are for 65 plus. But he literally referred me to the chronic fatigue department that's part of Mayo. Like, he's like, your fatigue is so bad. Why don't we send you to chronic fatigue? So from there I went and I got a chronic fatigue syndrome diagnosis, which is a dead end diagnosis. It's just a process of elimination. Like, if you don't have Lyme, you don't have STB, and you don't have Epstein-Barr, like, congrats, you've made it to chronic fatigue. here's a pamphlet on how to cope. Like there's no treatment. So.
Oh, fuck that. Yeah. It's just like a thing they say you have because they have no idea what you actually have.
Exactly.
Is that right? Oh my
yeah,
God.
there was no blood test. No, I mean, they did blood tests to make sure I didn't have other things, but there's no markers to say, oh, yes, you have chronic fatigue syndrome, like whatever that is.
Oh, no. Whoa.
So,
That really stinks. And then I guess you found eventually, did you do anything with that diagnosis, or did you know that's bogus and go to a different sleep study?
yeah, I mean, I did it for a few months and thought about going on some stimulants that he talked about. And actually, I think the doctor's explanation was like something sensitization, like what was it? It was like basically he was saying that my nervous system is amped up and like, oh, somatic symptom disorder. So he's saying you have some symptoms and then you focus on them and then your nervous system gets amped up in response and it's a vicious cycle, which is actually kind of eerily similar to like the UARS nervous system issue.
Yeah.
But yeah, long term, I didn't accept it. No. Yeah.
Right. And then eventually you found a sleep lab that, what made you go back and then get, the real diagnosis? How did you get lucky enough to actually get diagnosed?
I think I got like another sleep study after that with scoring with 1A that showed a decently high AHI, and actually it didn't even score RDI, but I had found out enough at that point where I found the UARS Reddit and realized that like I needed to get a DICE, like a drug-induced endoscopy. And so I went and got a DICE. And that was kind of like the starting point of like my treatment and also kind of the end of my diagnostic quest, where I was like, you know what? I don't need to go find a perfect lab that scores RDI, because my DICE showed full tongue-based collapse, full soft palate collapse, full epiglottal collapse, like everything.
Right.
And I could hear the surgeon like on the audio being like, wow, this is the smallest airway I've ever seen.
Oh my God.
Yeah. So
brutal. Yeah.
That was my answer. So.
And that was that's a definitive answer. Wow. And what did the sleep study find? And can you explain the 1A to people?
Oh, sure. Yeah. So, I mean, the sleep study, I had an AHI of 11 on my second sleep study. Mind you, the first one was an AHI of 15, which is already moderate sleep apnea. But the way that sleep labs score right now, if they're accredited with the AASM or the American Academy of Sleep Medicine, they can score with the 1A standard or the 1B standard. And the 1A is what AASM says, this is our recommended standard. Like what you do is you score each respiratory event with a 3% oxygen dip. So if I had a 10-second hypopnea and my oxygen goes from 97% to 94%, then that would count as a hypopnea under those scoring standards. So that would get marked to my AHI index. But if they were scoring with 1B, which is accepted, but it's not recommended, but any lab can still use it, then the 1B standard requires a 4% drop. And so my drop from 97 to 94 wouldn't be enough. I need to drop to 93 for that to count. And so they can just literally mark it as like good sleep, no respiratory event, even if I stop breathing for 20 plus seconds. If there's not a dip in oxygen, they don't count it. And the brutal thing about it is that insurance companies that are funding these tests and are funding like treatment options don't reimburse 1A. They reimburse 1B. So the standards for Medicare in Medicaid.
Mm.
They use 1B as their scoring standards that they reimburse, which incentivizes labs to use the 1B standard, and they're not going to get paid for 1A. And so even Mayo Clinic uses 1B. And then, so there's not really a good reason to use 1B because like it's been shown that 1A is more effective and it catches more people like you and I that have legitimate breathing issues. But then if the money's not there, then why would anybody switch? So
that's, oh my God, that's so sad. I have two questions. Maybe, one is then how is your letter, what are you doing in your letter and how is that going to change things? But then two, I was also wondering about, how RERAs fit in that. Maybe you can explain that to the audience. And I guess you weren't aware at the time when you were getting your diagnosis about RERAs. Otherwise, you probably would have advocated for your rights to have them scored. But yeah, can you maybe, talk to us about these things?
Sure. Yeah, I don't remember exactly when I learned about RERAs. I've come such a long way from when I started that it's all starting to blur. Everybody starts at the same spot going into this, not knowing anything.
Yeah, really.
RERAs. So RERAs stand for respiratory effort related arousals. And those are basically anything that are less than hypopnea. And when I say less than a hypopnea, I just mean airflow wise. So like in apnea, you have to have 90% reduction in airflow. Hypopnea, you can have 30 to 90% drop in airflow while you're sleeping. And then a RERA is anything that's less than 30% that didn't get picked up by those two criteria. It still disrupts your sleep and still ends up in an arousal. So you wake up from, trouble breathing, essentially.
Yeah.
But not all labs are required to score it. So there's no incentive for labs to score RERAs because your diagnosis for sleep apnea doesn't come from RERAs. And they don't get paid, they don't get reimbursed for scoring RERAs. But there's a whole subset of people that might not fit under an apnea or even a hypopnea the whole night, where you're having, like, say you start out with a tiny airway and your flow limitations are really subtle, but they're there, and you're waking up the whole night, or you can't even enter deep sleep or REM sleep, like you said. And you might even be having like a RERA every minute, and you're going to show up on a sleep study as perfect. You're going to show up as like no sleep disordered breathing at all whatsoever if they don't score RERAs or RDI. So that is the trouble with RDI. And the even worse thing is that some labs say that they score it, and you're like, okay, this is great. And then you go and you get your sleep study result, and under RERAs it says 0. And you're like, oh, okay, 0 RERAs. And then you find out that they actually just put a 0 because they didn't score it, but they claim that they scored it. It's a really weird phenomenon. But
has that happened to you? Because it happened to me once where they said they would score it. And I don't know what happened. Maybe the sleep technician just wasn't told, or maybe that one sleep technician wasn't trained, because I had been to that same sleep lab before, and there they did score it. It's just the second time around they didn't. And the craziest part is that I had the same doctor, and 2 years before, when I was waking up 70 times an hour, the doctor said, oh my God, this is awful. You have to get this treated. Let's do surgery. Let's do anything. And I was like, okay, yeah, great. Thank you for your feedback. And then when I went back 2 years later and the sleep technician scored a 0, the same doctor said, you're completely fine. Go to the psychiatrist. They'll help you out. Just don't think about sleep. And I was like, this is insane. You're the same doctor, the same sleep lab. But yeah, what do you think happened there? And how did you know about the the RERA issue, and did you have experiences with that?
Yeah, same thing happened to me. I mean, that's just sad. He's just reading off a report, which is what every doctor will do, I guess. But it really does depend on the sleep technologist, which is why I'm excited to be learning what I'm learning about for my sleep tech studies. But yeah, the same thing happened to me. So they said they scored RERAs, and I went in and then I saw my RERA number and it was 0. And I was like, are you sure? And they were like, oh, yeah, we scored it, but you must not have had any. And I think that might have happened to me on a few sleep studies. I'd have to go back and check, but it's just kind of a crime, because it's one thing to say we don't score RERAs. It's another to say we score RERAs and you were a 0 and you're good to go. See you later.
Yeah.
Like, not
doesn't that classify as like malpractice or something, you know, sending you off? And
it's
then
definitely unethical. Like, it's
right. You must have had like the best night's sleep that night because you had 0 RERAs. You must have like woken up super refreshed.
Yeah, you know, I took a horse tranquilizer and that covered it. So, yeah. Yeah, I don't know. I don't know what to tell you. I mean, it doesn't even stop at RERAs. Like, RERAs themselves have a very strict definition for what constitutes as an arousal.
Yeah.
And if you don't have a 3-second arousal on your EEG, which are the brain electrodes that measure whether you're awake or not, if you don't have an arousal above a certain number of hertz for 3 seconds, it doesn't count. And so you might be suffocating for 20 seconds and not have the arousal that triggers that RERA definition, and it's not going to get counted. So there's a whole spectrum of different things that happen as a consequence of respiratory events.
That's crazy. I remember you telling me about that, and I didn't know how arousals were scored, that it was a 3-second minimum. Like, and that's a 3-second of intrusion of like alpha waves or something, right? Into your whatever delta wave length, sleep.
16 hertz is like the specific definition, which I guess technically could be alpha waves, but usually is more like beta waves. 16 hertz is like you are definitely like wide awake, like no doubt about it.
Yeah.
Sometimes like even 8 to 13 hertz, you can be awake, and that's like the frequency that your brain's going at. So if you're at 16 hertz and that's the minimum, like you just got like zapped, like you're awake, like
So somebody like threw a bucket of water on you. Now, is there like a limitation to, I guess, why is it 3? Is it because it's just easier to spot for them? Do they want to make sure it's an arousal? Is it also like the instruments maybe can't pick up on something that's like shorter, like, or is it really just random, kind of like the OSA DSAT rule, and we have to be choking for so and so many seconds, and it's just arbitrary?
I mean, I don't know exactly how they came up with the 3-second rule, but I think there is a big concern. Like, everybody's worried that if you set the threshold too low, you're going to pick up on a bunch of random arousals that aren't related to a respiratory event, which I totally understand. Like, you don't want false positives in your tests, but the way that things are set up right now, it is way skewed towards false negatives, to the point where it's like, we have an entire population that's showing up with false negatives. So I think we do have to like re-examine that as like a community, and like, what is the correct definition of an arousal? Or like, if you get kicked out of REM sleep and you go to N1, but it's only, you go from like 7 hertz to 13 hertz, and you're not getting the deep sleep you were getting before, but you're not at 16, then, doesn't count.
Right. So we just took a little break, but where we left off was on brainwaves. And I had a question for you on that note. Is, with UARS, we have a lot of arousals where, the brainwaves look different from delta sleep or whatever. But then also I'd read that we have more alpha wave intrusion on our sleep than people with OSA. Could you explain that a bit and what that means?
Yeah, definitely.
Like that.
So the wavelength that you have during sleep is basically the different frequencies are dependent on how deep the sleep is. So if you've got like alpha waves or alpha wave intrusions are at a very high frequency, because that's pretty close to wake. If it's not wake, it's N1 or it's somewhere high up there. So that's like 8 to 13 hertz usually. And if you're in deep sleep, that's like the slowest wave of sleep. So those are going to be like really big, slow waves. And if you get an alpha wave intrusion, it's going to look like much thicker and denser. And that's essentially like a micro-arousal in the middle of your sleep. So you might not be totally awake and you might not remember it, but you're kicked out of deep sleep, at least for the moment. So yeah, that's definitely like another source of arousals that like the sports don't catch.
Right. And so are they they can be very short then, I guess? They could also just be a couple seconds long. And then how would you score it as a RERA? You would have to correlate it to respiratory effort. So that's what those straps are for around your chest and abdomen. Is that right?
Yeah, I mean, I don't think that would get scored as a RERA because the definition of a RERA is above 16 hertz for 3 seconds.
Oh, okay.
I think I would score that under like a flow limitation, which is a category underneath RERAs, which just means you have the flow limit showing up, but you don't have the second 16 hertz in the EEG. That's what that would be. And right now, flow limitations are definitely not scored.
Right.
But it's something that I'm working on requesting in my letter. So.
Oh, yeah. Right. Getting back to the letter, what are you requesting? And yeah, could you explain it to us a bit?
Oh, sure. Yeah, quite a bit. So I started simple. This whole letter, as I was writing it, I was talking with doctors and I was talking with friends and patients. And I just started simple. And I said, we would like to see 1As required, not just, recommended, but required. So that insurance will be forced to follow. We would like to see RERAs required. Like it won't be any financial burden on these labs to score RERAs because they're already set up to catch everything that a RERA would be. You need a nasal cannula and you need the EEG sensors that's already used every night. So the only burden that it puts on the lab is to ask the tech to score it and then to ask the doctor to take it seriously. But yeah. And then the third thing is we want to score flow limitations, which is probably the most controversial, but it's super needed because it doesn't stop at RERAs,
Yeah.
So for flow limitations, Dr. Robert Thomas has done some work in this, and there is absolutely like a huge portion of us that are getting flow limits the whole night that aren't getting scored. And I think his work found that on average, like 95%, I'm trying to remember if it's asymptomatic or symptomatic, so I might need to double check this. But 95% of patients that are asymptomatic have less than a third of their entire night with flow limits. So if you have over 30% of your night has flow limited breathing, it's almost guaranteed that you're going to be like symptomatic of sleep disordered breathing in some way.
Interesting. Yeah. Right. So, what's their name? The researcher?
Oh, Dr. Robert Thomas. He's the guy who invented the expiratory enhanced rebreathing space, actually. So he's amazing. He's giving me some feedback on this letter as well, and it's just he's like one of the pioneers for sure in this space. Okay, this is
This is the exact quote. So I think this may have actually been a Guilleminault study, but he's still done a lot of work in flow limits. So yeah, 95% of asymptomatic healthy adults exhibit inspiratory flow limits for less than 30% of total sleep time.
Interesting. Wow. Okay. That I think is that would make a huge difference if they started scoring flow limitations and like normalize the population so we know like what leads to symptoms and what does. Well, I guess he's done the research, so we already know. But it would be super helpful for us who fall through the cracks, you know. And also, it reminds me, I had I used this device called the Sunrise. Have you heard of it?
You know, I hadn't heard of it until I watched your video actually where you reviewed it. So that was really cool to hear.
Yeah. Oh, you actually watched that?
Of course.
Yeah. Oh, well, it was interesting because it was the only device that measured work of breathing by measuring flow limitations indirectly by measuring the movements of your lower jaw. These like micro movements. So it has a couple electrodes and it measures essentially the activation of your muscles in your jaw, because apparently you can correlate that to flow limitations, and they correlate really well, to the point where that's like all the data you need. Yeah, it's literally just a device. You strap it onto your, you glue it onto your chin. You can use it for 3 nights in a row now. And then you have really interesting data that tells you not just your AHI, because it correlated to that as well. And I suspect, you know, it's not going to be as inaccurate as like a watch pat or a sleep lab, but I think it's still it's very accurate. But I think in terms of measuring flow limitations, it's one of the only devices out there that does that right now and tells you if you're in the 80th percentile or, you know, if you're fine with flow limitations.
That's so interesting. So it's got like a chin EMG on the chin, you said, or like the mandible?
Yeah.
And what does that show? That shows like the bruxism or?
So apparently anytime there's a flow limitation that correlates with, I don't think they said actual arousals, but like actually I think they phrased it more as like alpha intrusion. So very subtle level kind of changes in brainwaves. Then you get activation of your masseter muscles, and it's just really small electrical pulses which this device can measure. They're just tiny vibrations in the jaw. And they've correlated that across thousands and thousands of sleep lab studies to not just AHI, but flow limitations, apparently, if I'm getting this right. And I thought that is so cool. Like if we actually had like a consumer wearable device that could tell you, you know, these are the flow limitations that you're experiencing at night. And not just these horrible, you know, you saw the video where, you know, I was evaluating kind of these different consumer wearables, if they could actually tell you something meaningful about your sleep, if you have like sleep disordered breathing. And essentially, long story short, it was no, they can't tell you anything really. But something like this, if this could become a consumer wearable, I think it would be so helpful for people.
Yes, that's so interesting. I think that there are a few home sleep studies that are equipped to catch those arousals. I think like WatchPat uses a different method that it doesn't pick up on the flow limits because it doesn't have a nasal cannula or any of the, you know, the chin EMGs, but it's catching arousals in a different way. But this is really interesting. I'll have to look into that. And actually, on that note, I have a graphic to share if you'd be interested in seeing some of the ways that flow limits can cause arousals or
please.
Like, consequences.
Yeah.
Just figure out how to share my screen. Do you know?
Let's see. Do I have to give you permission? Maybe. Let me try.
It says. Perfect. Okay, I think. Is this facing my screen?
Not yet. You shared it though, right?
Yeah, so it says I'm sharing.
Okay, maybe if I do this. But it's just a black screen next to us, right? In the box.
Oh yeah, I do see that's a black screen there. Let me see if I can try a different way. What if I shared? Okay, I'm gonna try this one more time. Let me know if it works.
Ah, there we go. Add to stage. Yeah,
Oh, okay.
cool. I'll make it full screen here.
Oh, sick. Okay. Yeah. So this is a graphic that I'm actually gonna be putting in my letter. And I found this in paper, and they measured all the different kinds of physiological responses to a flow limit in different sleep apnea patients. Well,
Yeah.
they measured three things. They measured oxygen desats, they measured an EEG arousal, and they measured heart rate increase, which is one of the primary indicators that shows like some kind of micro-arousal or an increase in sympathetic tone. And what they found, I don't know if you've seen like a box and whispers plot, but basically what it shows is their entire group of patients is split into these categories. So the median line, that line here is like the median. The top line is 75% of patients, and then the rest of the 25 are in this line here. So you can see that the majority of patients, like over 50% of patients, had an increase in heart rate in response to their flow limit, but almost 10%, almost less than 50% almost showed an actual oxygen desaturation. And so you can just see on the scale of is evident that like an EEG arousal is definitely better than an oxygen desaturation for catching events, but it's not perfect. And it's not as good as heart rate.
Wow.
So clearly not the whole picture.
Right. I guess that is interesting. That is that much higher with the heart rate increase. I guess the thing is to rule out, heart rate increase, because your heart rate can increase in REM, right? And just because there's all these different reasons why your heart rate might increase, but to make sure that it's actually a respiratory related arousal, you would have to correlate it with EEG and the respiratory effort.
Yeah, I mean,
right?
These heart rate increases are specifically after a breathing event. So if you have 10 seconds where you stop breathing or you decreased in breathing, and then you had a jump in heart rate, I don't remember exactly what they used, whether it was 3 beats per minute or more. But if you have like a clear jump in heart rate, and right after a respiratory event, it's happening again and again and again, it's a pretty good indication that it's due to the respiratory event, unless it's happening like throughout the sleep study independently, in which case maybe you've got like a heart condition going on or like restless legs.
Oh yeah, I just meant during REM, if for instance or restless leg syndrome, exactly. But apparently your heart rate also varies quite a lot during REM when you're just sleeping and you have emotionally charged dreams or whatever. But yeah, what you're saying makes sense. And then I guess instead of correlating the EEG to respiratory effort, you can just use heart rate, right? Because that would be easier, I guess. You just look at the spikes in heart rate.
Yeah, I mean, heart rate is definitely one of the huge ones. Another is like, do we use the 16 hertz for the EEG, or do we use like a certain jump, or like is this patient stuck in one sleep the whole time, or it like gets jolted from REM to N1 every time they have a respiratory event? I think heart rate is one of the biggest tells for like.
Which reminds me, I think the watch pad works that way. It measures not heart rate, but the
arterial tone, I think it was.
Yeah. Arterial. Say that again. Arterial tonometry.
Yeah, you got it. You know it better than I do.
It's like this. It's for the viewers. It's kind of like this capsule. You put it over your finger, and it's actually quite tight, and it hurts after a while. But it measures like the very small pulses in your blood vessels. Essentially,
Yes.
I'm not quite sure.
It's like blood volume and blood pressure change.
And then they've just correlated that to events. Is that right?
I believe so. I haven't actually looked at WatchPat in a while, but I think it correlates pretty well with an arousal. Yeah.
And I also heard they could correlate just the normal PPGs, the ones that you put on your finger that measures your heart rate. They've correlated those to respiratory events really well, and that they track,
Okay. PPG, is that measuring heart rate or is that measuring oxygen or?
It measures both.
Okay.
Mark, I think. But yeah, so you just pulled up that graphic. Are you then putting that in your letter and arguing for, some differences there, or how does that factor in?
Let me see if I can just pull this up. So I think that RERAs and scoring 1A is an obvious ask, and it's been asked for decades now. And I think flow limits is a slightly less obvious ask, but doesn't make it any less important. But I really needed to make the evidence, like pretty thorough for our argument, which is that flow limitations are important too and need to be scored. And so what we're kind of arguing for flow limits is like, okay, everybody's scared. Here's what everybody's scared of when you're measuring flow limits. They're worried about like your typical snorer who doesn't have any symptoms. They're just snoring a lot, and snoring is a flow limit. And what we're arguing is that a simple snorer is not somebody who would get scored under the criteria that we're proposing. So we need a couple of things to be true to score like a flow limit event. So we need the person to be symptomatic, first of all. Like they need to state that they're sleepy or they're fatigued and they have coming in with some problems. And then we need a quantitative threshold. So we need like the total amount of sleep spent with the flow limit to be over 30%. So that it's not just like, oh, they have a flow limit here and there, let's add it to their index. It's like, no, this person is clearly flow limited throughout the whole night. And then the last thing, which is the most important, is some kind of autonomic consequence. So whether that's a heart rate increase or a blood pressure surge, like with what WatchPat detects, or like sleep fragmentation with alpha wave intrusions. One of those things needs to be correlated with the flow limit so that if we have a simple snorer who's snoring the whole night, it's not going to be confused and we're not going to like tell them to go get a bunch of surgeries, even though that's not even the first line of treatment that's usually suggested for people with sleep breathing. But that's kind of what we're suggesting for what needs to be scored for flow limitations.
Yeah.
And
with
so,
the hope.
Yeah.
Oh, go ahead. Yeah.
No, you go ahead.
I was just going to say, so that's with the hope of basically having less false negatives and picking up on, because you're already arguing for RERAs being measured, or is it just to get more granular data essentially for everybody, just to, yeah.
I mean, RERAs are important, but they're not everything. They're not the whole story. And so we're still systematically excluding a whole portion of people if we just stop at RERAs.
Right. Wow. So you're saying there's another subcategory of people who may not even be flagged, even if they were to be scoring RERAs.
Yes.
Their breathing problems are so subtle that the 3-second EEG arousal rule and whatever classifies it as a RERA, it won't pick up on those people.
Yes. Yeah.
So they have very subtle problems then. I mean, sleep disordered breathing. Yeah.
It seems subtle, but if you have like flow limits throughout the whole night, you're struggling to breathe the whole night, or your body is forced to work super, super hard just to be able to sleep, and you've got heart rate spikes throughout the whole night, like, you know, there's definitely something going on. Your arousal index might be off the charts, for example, but nothing's showing up under RERAs. But
yeah. Right. Yeah, and it's so cool that you're doing this, and you know, bringing that back to the arousal threshold. I guess it also factors. You said, you know, work of breathing and all this, and I was just thinking about the fluid dynamics work that I'm doing, and seeing in people's airways how the negative pressure builds up through their nasal cavity and into their, you know, down to the epiglottis basically, and that kind of correlates with work of breathing, and that, you know, in particularly small airways, you can basically visualize and see this person is working really hard to bring that air in through that airway. It's almost like you can visualize the work that their brain is exerting. And there was one researcher, I forget his name, but after or at the same time as Guillemot, and he was measuring the esophageal pressure of people and seeing what is the critical pressure threshold where people have an arousal. So at what point, how negative does the pressure have to get at that lower level where they're measuring it near their esophagus, that people, their brains wake them up. And he found, of course, it's a range, but he found that generally it's about 15 centimeters squared of H2 of water pressure, which I don't know.
Negative pressure. Okay.
Of negative pressure. He found that there is, in a lot of people, seems on average, that's the number where the brain starts waking up. And I would assume that's a big range though, and that's that average doesn't tell you too much, and that would be very different from person to person. But yeah, I don't know how this relates exactly to flow limitations, but somebody with
totally relates.
It does, right? I mean, there's just a direct connection I'm trying to establish. I guess the person with a lot of flow limitations is also going to have a high work of breathing throughout the night. But this kind of threshold effect kind of surprises me a little bit, you know, and maybe we talk about thresholds and all these arbitrary numbers, 3 seconds, 2 seconds, you know, you have to choke for this long, that long. It's more like, no, it's like all of it is a spectrum, and all of it is like a spectrum, and it's almost like some people just have beautiful sleep for some reason because their breathing is just perfectly fine and their brains can like completely shut down and relax, versus us, we have like probably hundreds of flow limitations an hour, and we just can never reach that level of parasympathetic kind of relaxation and sleep.
It's interesting you brought up PES, or esophageal pressure monitoring, because there's another controversy is whether the way we're measuring flow limits right now with a nasal cannula is good enough as is. And something I'm arguing in my letter is that it's not. So we used to use PES as a field a lot more, like 10 years ago. And it's gotten slowly cycled out, I guess, because it's uncomfortable for patients to tolerate. Like you've literally got like a catheter down your esophagus, and you sleep like that. I wouldn't want to do that either.
I imagine it makes it hard to sleep, right? And does it go through your nose, or do they probably, right?
Probably it would. I haven't done it before.
Feels like that would obstruct your nasal breathing a little bit as well.
Maybe. But the argument against nasal cannula is that you're picking up flow limits from your nose, and not all of us breathe through our nose, especially the people with breathing problems that are mouth breathers. Like you might breathe a little bit through your nose, or it might pick up a little bit of that, but it's not going to be as accurate. And so that's only part of it. And the other part of it is like sometimes like the pressure in your esophagus correlates super well with how hard your body is working to keep the airway open, but it doesn't measure perfectly with like how much airflow is being limited. So like if you've got a really small airway to start, the harder that you work to breathe, the less air that you get. Almost like the more air that you try to suck in, it's more negative pressure, the more the sides of your airway kind of get sucked together. So it's like this push and pull where we have to take these really shallow breaths. So we're starting with the baseline of like a tiny flow chart, right? Where we're just taking these tiny breaths. And then if there's a tiny fluctuation in that, is that a 30% drop? I don't know, maybe not. But we're starting with shallower breaths than like someone who's more phenotypically like normal, who's taking like regular sized breaths. And then like a 90% drop is super obvious in their flow chart. But yeah. And so that's kind of the argument is like, we need PEZ to pick up on the things that this nasal cannula is just not going to pick up on.
Right. You just made a connection, which I thought was very interesting. And that's that, you know, apparently people with UARS, we have shallower breathing, like our tidal volumes are lower than normal quote unquote population. But what you said makes sense, that we have to learn, or we have this adaptive way of breathing because of our narrow airways. Because if we were to have larger, breathe in more air, that would suck the airway close, shut. That's a good explanation for maybe where that partially comes from. Which is also another argument for, well, no, that doesn't make much sense. I was just thinking about also bringing respiratory rates down, you know? Do you think? Yeah, because what I'm doing now, and I'm really focusing on my respiratory rate. Something that I've noticed with, and this is maybe kind of branching out a little bit.
Sure.
But we can come back to the original topic. But one thing I found that correlates pretty well with how I feel is, yes, my like heart rate variability, because I wear this Whoop, because it is in what I think, what I found kind of the most helpful in terms of tracking my sleep, in part because it has a high resolution on heart rate at night, so I can see the spikes that I have in heart rate. Yeah, among all the trackers, it's one of the best in that, in that, and the sleep staging is very good. But it doesn't tell me like your sleep has been fragmented, or I can't really tell in that way. But it does tell me respiratory rate, and I found that correlates really well. Like if my respiratory rate is quite high, then I just feel like trash the next day. If it's pretty low, I feel much better. And I think it might be two things combined. One is just respiratory rate kind of reflects the balance between your parasympathetic, sympathetic nervous system in general. So if it's lower, it means you're more in a parasympathetic state and the balance is there. But then also if it's higher, it means I probably had more respiratory events, because every time you're put into this event, it destabilizes our breathing, at least with UARS, it destabilizes our breathing, and then we start breathing heavier to kind of recover from that event, if you will. And but then I was also thinking it might have like another effect where, if I just breathe, if I'm breathing more quickly at night, that means I'm also, it's working harder to breathe, and it's almost like I'm also exerting more of that negative suctioning effect on my airways throughout the night.
That was my first thought, was like, okay, so we're taking shallower breaths, right? So we're getting less air in and we're getting less air out. Like, sorry, our tidal volumes are lower, which means maybe, and I'm just speculating here, but maybe we have to speed up our respiratory rate a little bit with those shallow breaths to get more air in and out for a total like minute volume, which is, it's a respiratory term to describe kind of like how much gas exchange is going on per minute. And so that makes me wonder if like maybe those nights that you have a slower respiratory rate, you had less airway resistance and you could, I don't know, maybe take like slightly deeper breaths or something. It's hard. I don't know.
Maybe. Well, one thing I've noticed, and this is where we're getting into another topic, I guess, but since I've been taking the Guanfacine, I hope I pronounced that right, not the Guanfacine or whatever, my respiratory rate went down. And I guess for the viewers, I'll just explain real quick what it is. But it's definitely related to arousal threshold, and it's an interesting one. I came across this one actually reading a book on trauma and sleep. Maybe I'll talk about that later because it's really interesting as well. But it was a book that somebody suggested just months ago, and I read through it. I was like, wow, this is amazing. They're talking about one area of the brain called the locus coeruleus. And that's, again, I hope I pronounce these things right, but I don't think it matters too much. But it's in the brainstem, and it's the kind of the main, I guess, thoroughfare of internal, external kind of stimuli and for releasing norepinephrine into the brain, which is kind of an activating neurotransmitter and is, responsible for, your brain figuring out what's important at any given moment in time. And it's essentially a precursor, I'm pretty sure, to adrenaline, right? So it's basically it's very it's stimulating, activating. Has a lot of different effects, and it's also very important in sleep and in your arousal threshold, apparently, and in determining, what your brain detects as threatening or important during your sleep, even. But anyways, they found in this book, maybe I'll tell you about the book real quick, because they found that people with PTSD and this also, like with anxiety disorders and so on, have an overactive LC. Let's just call it that, locus coeruleus, and that they found this vicious cycle in almost all of their patients where there's a sleep disorder behind or associated with their mental condition, and that just treating the mental condition would almost never solve the actual, it was very difficult to solve the mental condition without addressing the underlying the comorbid sleep disorder. I'm not implying, one is because of the other, but they're saying, like, if the person has, and they said, insomnia, bad, of course. If a person can't sleep, it's going to make everything worse if they have PTSD or depression. But they said sleep apnea, the worst. You have to address it because it just really ruins the brain's ability to deal with issues. So they said it's basically this trauma loop where you get a person into traumatic events that they didn't deal with or weren't able to. It worsens their sleep. The sleep gets worse. It makes those traumatic events even more salient and just, they think about it more, they're less able to process it, their sleep gets worse, and it's just this thing, it's self-perpetuating cycle. Anyways, all that to say, I thought the book was great. It's a little bit wonky, so I wouldn't recommend it necessarily to everybody, but it got me into thinking about their treatments, also what they had recommended for people with PTSD, and which they use are, there were two drugs, I forgot. One is mirtazapine, and the other is something with a P. But both of them, what they do is they decrease the ability of norepinephrine to bind to these noradrenergic receptors in the body and in the brain. And they essentially...
So it's like a reuptake inhibitor, or is it it's like something like that?
Apparently they bind to these adrenergic receptors themselves, but they also reduce the release of norepinephrine in the body and therefore the availability of it. But they do bind to the receptor. So it's a bit of like this balancing out act.
Okay.
It has an overall effect of reducing sympathetic tone. It definitely reduces blood pressure and respiratory rate and everything. But they found it very effective for treatment of PTSD, and especially PTSD with people who have nightmares, intrusion of nightmares into their sleep, which all that research around these drugs and these brain areas that are involved in sleep brought them to the conclusion that, oh, the LC is really important in addressing these depression symptoms, PTSD symptoms, but also sleep. Anyway, so I took all of that got me into thinking, oh, let me look into these mirtazapine drug and this other one. But I found they have quite negative side effects. They, suppress norepinephrine quite like everywhere and can make you quite drowsy, etc. With UARS, I don't want that. I don't want to be more fatigued. But then I found Guanfacine, which apparently has been used in some instances and has, less side effects. And some people have been experimenting with it also in the forums with some success. And, I was just thinking, if these authors kind of theoretical framework or whatever, even has like some validity, it means that Guanfacine should help. So it's kind of an experiment for myself as well. But yeah, anyways, I talked a lot there.
Yeah, no, I have a lot of thoughts on that. I think what you're saying is really interesting because I've been looking into a lot into norepinephrine in like the opposite sense, where I read some things that said it was highly implicated in muscle tone and like airway muscle tone, and that you can increase your norepinephrine availability, you can increase your airway tone. And I don't know if you've heard of like the new Apnimed drug. I was just looking it up. It's got two components into it, and they've gotten this drug through clinical trials, and it's done super well so far. But it's a two-part drug, I think, that's designed to treat sleep apnea. It's one part atomoxetine and one part oxybutynin or something like that. And oxybutynin is an anticholinergic, and so I've mixed feelings about that for a couple of reasons. But atomoxetine is a selective norepinephrine reuptake inhibitor. And basically what I think the reason the drug is doing so well is because it increases muscle tone. So that made me wonder about your Guanfacine and if that might have some effects on norepinephrine. Google is saying it's an agonist that mimics the effects of norepinephrine. So maybe it decreases norepinephrine release. So I don't really know.
It does. So, but that's the kind of it seems like a contradiction, but I think it it does increase tone a bit and norepinephrine within the body by mimicking it. But it has, I think, most of the effect in your prefrontal cortex. And that's why it's used in ADHD a lot, because it kind of stabilizes norepinephrine transmission. Apparently in ADHD, it's kind of like you get these bursts, whereas this just makes it kind of more this steady hum, which is what you want. But it also, by doing that, somehow just also reduces sympathetic tone. But I think it's mostly through exactly inhibiting the release of norepinephrine. It's a bit counterintuitive, but yeah, I think anything that decreases the alarm bell in my brain without having that. This is why I'm hopeful. Is I don't think the Guanfacine has that negative side effect of the hangover the next day, right? Because like I've tried other things like the Z drug, Zolpidem. I've given Xanax a try, just out of jokes. Let's see if that works. And sure enough, I slept like 14 hours on Xanax, but my airway is probably collapsing because it reduces muscle tone, and I felt like trash when I woke up because I still have the Xanax coursing through my brain. It's making my fatigue even worse, and my sleep was probably awful. So it's like those don't work, right? But maybe something more subtle that decreases the alarm bells, but doesn't have that next day effect. Something that I'm looking for,
Yeah, I mean, I see what you're saying. Like you kind of want to dampen your arousal threshold, I guess, is what you're trying to do.
And Trazodone is another one that people are using for that purpose. It's a serotonin agonist and reuptake inhibitor, and apparently it does work. It reduces the arousal threshold by 30-40% or something. I mean, that's the study that I found on it. Also worth a look. But
yeah, it seems promising.
Yeah, I'm also interested in this. What is the drug called that you described?
Are you thinking of the one I just described or a different one?
Yeah, the one, that they did clinical trials on.
Yeah, Aptamed's drug. It's 2 drugs, and the one that I was focused on is called Atomoxetine.
Atomoxetine?
Yes. But I think it might do something different than the drugs that you're trying to do, where it's increasing the availability of norepinephrine in the brain. Also, weirdly enough, a non-stimulant medication that's used to treat ADHD, just like Guanfacine.
Kidding. They're doing the same. That's the same.
I don't know if it's working because one's an agonist and one's a reuptake inhibitor. So I don't know how that works, but maybe they kind of work towards the same goal.
Yeah, maybe. Right. It's kind of like it's a agonist and a reuptake inhibitor, but I guess both have similar effects, but you could combine them both of them to have a larger effect, I guess, but
I'd ask your
second overkill.
But maybe I don't really know about drug interactions in that sense.
Right.
But speaking of drugs, have you heard of Quviviq before?
I tried it. Have you tried it?
I haven't tried it. No.
Yeah.
What did you think?
Yeah. Okay. I'll tell you, and then I want to hear what you think. So yeah, of course it was like, it came out and I was like, oh my God, I have to have this. I got to try it. This sounds amazing. The next new thing. Or it's just one thing that has like a 2% chance of working on me. So I tried it. I woke up the next day unable to move. I literally couldn't get out of bed. I tried to. I had crippling depression. It was literally like I've never had that before, where I felt like I couldn't move my body because I didn't have motivation to do it. And so yeah, I did not take it after, and I have a theory of why. I think that for the viewer, Orexin is kind of the main on-off switch in our brain, and people with narcolepsy, and then their Orexin neurons are atrophied, and they basically can just nod off at any time. It's called cataplexy, when they just fall asleep. But Orexin inhibitors are inhibiting the Orexin, which is kind of the main wake promoting agent in your brain. That's my 5-second spiel. But and I tried it. It's a new way of giving you sleeping. It's a new type of sleeping pill essentially, I really had bad reaction. And I think it's because my body has adapted to to being awake and driven, not through dopamine, but through orexin. This is a wild theory, speculation, but it's like my dopamine release and whatever is so messed up through my bad sleep that, to stay awake, I really need that orexin.
That theory actually makes sense to me because there's a whole lot of neurotransmitters involved in wakefulness, and I'm sure sleep apnea really messes with those. So your brain probably has to like recalibrate and figure out what it's going to needs to amp up in some other areas. So yeah, that could be.
Yeah, my brain was just adapting to the years of, I don't know. I could give it another shot, but I'm tempted not to because it was just so awful.
Yeah, that doesn't sound good. So now you're scaring me. I was going to try it, but I don't know.
Yeah. But it's worth a try. I mean, I would try anything, right? Have you tried any drugs, like medications?
Honestly, not really. I've like stayed very clear from drugs. So if I just take like 0.5 milligram of melatonin, I will wake up the next day with a hangover. I mean, I wake up every day with a hangover, but I will wake up the next day with a worse hangover.
Yeah.
So, and melatonin's like, it's not even a drug really. It's just a hormone. So, yeah. I mean, I've tried Ambien once. I've tried, I think, Trazodone once. Oh. And none of these drugs were able to like, it's my personal belief that you can't out-medicate a small airway.
Yeah.
Like, I just want to break all my jaws and move them forward and see what happens,
Yeah.
Like, obviously, if I could make BiPAP or ASV work, I would have done that by now. But yeah. But maybe for a night or two, Trazodone could, I don't know, maybe there's something to like decreasing arousal threshold for a night or two just to give your body like a different kind of sleep or something. That could be
possible. Yeah. When the nights I would use Zolpidem were the nights after days or nights that I had very bad sleep, or I actually had like a small drinking phase. This was like a year or two of my life where I was able to actually like kind of tolerate drinking. And and then after being hungover the next day, I would just take a Zolpidem, go to bed at like 8 p.m. and then surprisingly I'd feel great the next day. I don't know what it was. I think it was just the recovery sleep, but something about Zolpidem though, it definitely gave me deeper sleep. But the thing is, it's just such a catch-22 because the next day you're not going to sleep as deeply because your brain is registered that, the drug is there and going to help you. It's almost like I got used to it so quickly that my brain wanted it again to be able to sleep that well, and yeah. And then if I tried doing it maybe 3 or 4 days in a row, but after day 3 or 4, it loses its effect essentially, and you just get negative effects from it. That was my experience.
Yeah, I wonder if you felt so good the first day because it suppresses REM sleep. And I don't know what your sleep disorder breathing is like, but I feel like a lot of people have heavy REM sleep events. So
yeah, definitely that's happening for sure. I mean the REM sleep events. Yeah.
So could be.
Yeah.
I think it's a pretty safe medication to try. I think that's like a starting medication that a lot of sleep doctors will start people on. So.
Trazodone?
Mm-hmm.
Okay. Even though it's a serotonin, a lot of people complain about SSRIs and the side effects. I was just wondering if Trazodone had similar side effect profile or.
Yeah, I mean, actually, that's true. I have heard some people say Trazodone gave them a worse hangover than even Ambien. So maybe it's not like great, but I think it's worth trying. It's not going to like suppress your airway tone as much as like a benzo would. So,
Right.
I don't know.
Okay. So what would you suggest if you had to suggest anything like for people to do or like try on like if they thought my arousal threshold could maybe be tweaked, you know? Yeah.
Oh, yeah. My first suggestion would be get a 10 millimeter advancement. And
Yeah, both jaws. Okay. Yeah.
yeah, the jaws.
Yeah.
My second suggestion, I don't know. I don't know enough about the drug landscape. I'm so interested in it, but like I've heard somebody say Muscimol. I think that's how you say it. It's like something they like to use.
What is it? Can you say it again?
Muscimol. It's spelled like
Muscimol.
Muscimol. So it works on GABA. It's a GABA agonist. Kind of a sedative, but also maybe hypnotic.
Yeah, I didn't do well on GABA.
What do you take GABA?
Yeah, just the straight up GABA. Even I think Zolpidem also are GABA inhibitors. The Z drugs, agonists, GABA agonists. But yeah.
I mean,
I
have you found any drug that's worked well for you? Or
I guess Guanfacine.
Guanfacine?
I might even go so far as to recommend. I mean, not doctor people, don't do anything I say. But it has so little side effects. Apparently, you have to be careful if you have low blood pressure. Already, because it lowers your blood pressure more. So if you have that and you get dizzy or you ever faint, probably not a good idea. But otherwise, the side effects seem very minimal if you're on like a low dose. And yeah, but
I mean, I wonder. So, do you take Guanfacine like before bed, or do you take it when you wake up in the morning?
Before bed, yeah. And one thing I've noticed is I dream more and I dream longer, but I do wake up during the dream. So I tend to remember the dreams now. But when I do, they seem more coherent. Like there's a story behind it. Like I used to wake up and when I remember my dream, it's just like a fragment, like a shape, a color, like a scene. But now it's like a full story that I remember. And that to me indicates that I'm having more consolidated REM sleep because the story is allowed to unfold itself in my brain, you know? Whereas before it was like I'd hit REM and all of a sudden it was just like be hitting like jagged waters and it was just, you know, I'd wake up or not even wake up and remember, but just my brain wasn't allowed to carry on the dream. But now, and there was something other interesting that I found that might help explain it. And you might know more about this as well, but it was saying like that people with low arousal thresholds, this is something I found through ChatGPT, you know, just put in, tell me about a low arousal threshold. And it said that people with low arousal threshold tend to have, lighter sleep, makes sense, but they tend to be stuck in this fragmented N1 sleep where their brains aren't allowing them to get into the deeper sleep phases, and REM especially not. But that's very unfortunate because actually the deep sleep is easier to maintain for the brain. It's like your arousal threshold then sinks in those deeper phases of sleep. My theory then, if that is true, maybe you can comment on that, is that Guanfacine, you know, my theory is that Guanfacine is just helping me stabilize that first N1 sleep. And getting through that like rough, low, rough part where, you know, my low arousal threshold is waking me up and getting me into these deeper phases of sleep where I was spending less time before, maybe.
Yeah, maybe. I think it's really interesting that Guanfacine is what's worked for you because I've been so fixated on norepinephrine, like independently of everything that you just shared myself. And that reminded me when you said that I saw better sleep on Sunosi. Have you heard of Sunosi?
No.
It's actually, so it's a stimulant. It's an NDRI, so a norepinephrine dopamine reuptake inhibitor.
Oh.
And I didn't take it for sleep. I took it in the morning. But I found myself dreaming more on that NDRI. And that makes me wonder if it's increasing REM sleep or if it's just increasing my muscle tone, like my airway tone during sleep.
Mm-hmm.
So closely related to that.
Right. Did you feel better? Are you still taking it or?
Yeah, I took it for 3 or 4 months just to kind of get through the workday. And eventually the anxiety started to get to me. I mean, I'm already on the anxious side. So if I ramp up the anxiety, like eventually it's going to be too uncomfortable. So I don't recommend like stimulants for people long-term necessarily.
Right. So it was a stimulant.
Yeah. It's designed for sleep apnea, but it's like stimulating. And I thought it really helped me. Like, I wonder, we're kind of talking about medications to raise the arousal threshold, but I wonder if we could be talking about medications to raise the muscle tone in the airway instead. Maybe that could, help our sleep disordered breathing and help our nervous systems in relation to that not have to work so hard or something.
Yeah. Well, it sounds like that drug that you mentioned earlier does both then. I forget what it was called again, but the one with the studies.
Yeah.
Atomoxetine. Yeah, that one. Yeah. But speaking of stimulants, since you mentioned that, I was on modafinil for years. And this brings me back to what you said earlier about, doctors just, throwing their hands in the air because, the AASM isn't giving them any guidance and, they don't know about UARS. And essentially that's what happened to me when, I was first diagnosed, and then I got a CPAP. I used a CPAP for like 6 months. It was so hard to get used to, but finally I was like, okay, this is kind of helping, maybe 20%. But I went back to the doctor. I was like, I'm still waking up 3 times a week, just utterly dead and exhausted. And he's like, okay, well, ENT will check it out. They said, nope, sorry, nothing we can do. And then the doctor was like, okay, well, there is something called, he didn't give me a chronic fatigue syndrome, but he said, it's a technical term for the tiredness, that's the fatigue that's still left even after treating successfully, quote unquote, treating sleep apnea. And he said, the only thing we can do is give you a stimulant. And I was like, okay, well, that kind of sucks, but sure, give me the stimulant, great. And so then I was on modafinil for 3 years, and sure enough, it kicked my ass. I was awake, for sure.
I don't know what they put in modafinil, but it's like crack.
Yeah, for sure. Actually, I think it's more like the Coke. I think the crack is Adderall, but modafinil is more like this. It's a not that I'm.
Yeah, it's like poor man's Coke or something, like crack cocaine. I don't know.
Yeah, a bit. Yeah. But it's pretty smooth though. I gotta say, it's like coffee but less jittery. You're just awake. You're there. It actually does work for sure. And it's usually prescribed for people with again, narcolepsy. But the thing is, it would ruin my sleep. So after 4 or 5 days of using it, sure, it would work, get me through the day.
Yeah.
But then I would be so exhausted to the point where if we were talking right now, my eyes would start. I wouldn't be able to concentrate on what you're saying, and I'd just start shutting my eyes. It got to the point where it was that bad, and then I would have to stop taking it for 2 or 3 days and cycle on and off like that every week or two. So it was ruining my sleep and making everything worse. And if I were to continue taking that for the rest of my life, I'd probably get early onset Alzheimer's and whatnot. And so really, doctors, that's your solution. And so the work you're doing is just so important, because otherwise we're just going to keep getting those kind of band-aid solutions, which are not even band-aids. They're worse. Is pouring gasoline on the fire.
Totally. yeah, I've myself was on modafinil for a year just to get through college, and it got me through. But yeah, it's not a solution for sure. And the way doctors can like dismiss your symptoms or like your test scores and then go and prescribe you like crack cocaine and just see you off into the world, like, bye, go and have fun. Like, sorry, CPAP's not working for you.
Yeah.
It's crazy. It's really crazy.
Right.
So
Right. How much modafinil did you take?
so I took armodafinil. So yeah, so it's like slightly stronger, but I started on like a 75 milligram dose, I think, which is like half a pill.
Okay.
But
Yeah.
yeah, I developed a tolerance very quickly. And then I moved up to taking that twice a day. And then I was sitting in class and I felt like I was going to die if I didn't take more. And then I would like take another quarter pill like out of my pocket. And I was just like a junkie walking around with bits of modafinil pills in my pocket. It was so bad. It was so bad. And then I'd like go to sleep at night and just be wide awake and just like staring at the ceiling. And yeah, so.
I not sleeping at all. Oh my God, that sounds horrific. Yeah.
Yeah.
Oh man. Yeah. And then, but it got you through for a year, I guess.
Yeah, I was stupid. I combined it with Wellbutrin because I was like, this isn't enough. So I took both at the same time to get through my senior year of college. And yeah, I'm graduated now, but
Yeah.
I was schizo, so or I was a crackhead, more accurately.
Yeah. No, we've all been there. I mean, I only got through bachelor's with caffeine and coffee. Yeah, gallons of coffee and Mountain Dew. And that was quite painful as well. Obviously, that didn't help my sleep or anything really. But honestly, I wouldn't have been able to do it, I think. Otherwise, I needed that to just keep me focused and awake.
Yeah.
So, yeah, wish I had modafinil back then. But yeah, it really affected my whole life because, I mean, being in those kind of constraints where you're having to take these stimulants also just makes you very anxious and like, yes, focused, but not in a nice way. You're not focused where you can have a pleasant conversation with somebody. You're so focused that you're thinking, oh, what could go wrong? Am I spending my time with this person productively? Shouldn't I be like studying for a test? Or, you're constantly on edge about something. And that just, for me, it ruined my social life. I mean, it really, really did. And just made everything besides work quite unenjoyable. I mean, I just wasn't able to relax. So I was awake and studying and productive, but at a cost. And it wasn't. If I had to go back, I would have skipped college, to be honest. I mean, I'm saying that now, but I'm glad I have a degree. But
I can relate to everything you're saying there. Like when you push your brain into overdrive, like, and it's doesn't have the ability to, and you just like go, 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 go. I started developing like low grade anxiety to the point where, I feel like there's a scale of anxiety. So you have like, you have like social anxiety, and then you have like generalized anxiety. You're just constantly worrying. And then maybe a step above that, you have like OCD, and where you get into these like thought spirals and like what ifs, and then maybe like beyond OCD is like just straight up paranoia. And I went through that whole ladder in my year on modafinil.
Oof.
So
whoa, you reached the upper stages of anxiety.
I did. It was really bad. And like, thank goodness I had supportive roommates, but just like,
yeah.
What by the end of that year, it was like, was my degree worth it? Like, I don't know. So
We'll say yes right now because you did it.
yeah, there we go.
And, yeah. And maybe even your experience, our experiences, maybe even I'm not saying they were worth it, but there's like a silver lining. We can sympathize with people who have crippling anxiety, and
Yeah.
for whom it's very tough. But oh man, that was tough. Not even like a year, but like several years.
I don't know how you stayed on it for 4 years. I could never. That's wild.
Yeah, I don't know either. I mean, otherwise, yeah, I tried to keep a balance of also like healthy lifestyle. I never went out. I never drank. I sometimes, but rarely, and
Yeah, in moderation.
moderation. Yeah, yeah. But I was very work focused, and just everything was very organized. I'm a very disorganized person now, probably because ADHD and my lack of sleep. And but back then, everything was super organized. I'd go to the gym. I'd eat perfectly well. So I had all my ducks in a row, except for the sleep. The sleep was completely, ruined. But that was the only way I could function. And I realized later in life, when I didn't have these pressures as much and my job got more chill, that if I let that organization go and I do allow myself to enjoy myself more, drink more, whatever, and let some of those lifestyle factors go, then my life becomes quite unmanageable. Like it's very difficult to work and get things done, stay, physically fit, take care of my body, take care of other people's needs. Things break down quite quickly. So that's always been like one of the most difficult things with this sleep condition is just having to almost like just manage all the aspects of your life meticulously.
Yeah, I think it's hard for any adults without sleep disordered breathing to manage a job and a social life and working out, and you take a debilitating sleep disorder and put that in the mix. It's like you can't do everything. And I definitely relate to that. Like if I couldn't sleep like 10 or 11 hours every night, and I was waking up when everybody else was waking up and going to work at 9 a.m., by 5 p.m., I'm not a human,
Yeah.
So.
Yeah. Yeah. Do you think this is really a condition of really modern recent history, or do you think it's been around for hundreds, thousands of years?
Oh gosh, I don't know. I mean, I feel like we'd have no way to know, because like, what would this have looked like? We just are tired all the time. Like, I feel like people wouldn't have known enough to document it. But then again, it does seem to be some evidence pointing to like jaws shrinking. And so like, I think Neanderthals, in the skulls that they find, they all had perfect teeth. There was no like carotid or crooked teeth in their palates, and they all had like super wide palates. So maybe jaws have been shrinking over time, and maybe they're going to keep getting worse. Like maybe the next generation or two is going to really need the AASM to step up and include them in their scoring standards, because who knows? Like maybe we're the tip of the iceberg.
Right. Maybe, everybody's going to have to walk around with, or everybody's going to need CPAP in another 1,000 years or something.
Gosh, yeah. Yeah.
Yeah.
Oh,
No,
it's your annual, it's your jaw surgery. It's time, like.
Right. Oh, yeah. Yeah. Exactly. Right. When you turn like 17, everybody gets the jaw surgery.
Oh, yeah. To graduate high school, you must do a double jaw surgery. Your airway.
Right. Yeah. Yeah. To me, it's like, it just blows my mind that people could have lived with this and never have known that it's a condition, it's treatable, you didn't have to have it. But I guess even like 100 years ago, there would never have been a treatment. So it's like, okay, well, and yeah, it just makes me wonder, like, it's like, how prevalent is this really, and how many people are suffering from it and don't even know, and
Yeah.
yeah.
Take ADHD, depression, anxiety, so many other disorders where people don't get a sleep study. Even like it worsens things like bipolar, schizophrenia. So yeah, there's a million different things out there. Fibromyalgia actually is a big one.
Ah,
Yeah,
yeah.
there was a study where they took a group of fibromyalgia patients and had them take a sleep study. It was 28 patients, and 27 out of the 28 patients had sleep disordered breathing or like flow level.
Kidding.
Yeah. Yeah.
Holy shit. You're kidding. And this is one of those disease conditions where they don't even know what it is, where it's coming from, right? It's like one of these autoimmune diseases.
Yeah, it's lumped in with chronic fatigue a lot. I think it's slightly different. There's like more joint pain associated with it, if I remember correctly. But yeah, they don't know enough about what causes it and how to treat it. So
You know, I was worried that I was developing that because I started getting just not, it wasn't pains, but just like this dull ache in my joints. And it was getting worse. And I was like, whoa. That was the year that, no, 2 years where I got off of CPAP after my surgeries. And that's when I started developing it. I've been on CPAP again for the past year, and it's luckily went away again. But that's when it dawned on me. I was like, this can get worse. I'm just at the, even with over 20 years of living with this, this is still the beginning. It can get much worse. Like,
yeah,
I need to treat it. Yeah.
yeah, I've heard people say that they have like low grade joint pain or just like body aches from just like sleep deprivation. So I can believe that for sure. Yeah.
Oh man, that's scary. Yeah. Not
Yeah.
going with, you know, yeah. Fibromyalgia, is there anything else? Was it, well, chronic fatigue, obviously. IBS, irritable bowel syndrome, I heard was
There
great.
does seem to be some sort of gut like connection with sleep and sleep deprivation. I don't know as much about that, but I know so many people with UARS who have like just digestion issues or like maybe not even full scale IBS, but some people do. But like, you know, just like bloating or just like cramping and yeah, there's something there too. Yeah.
Yeah, I
That's
bet.
one for sure.
Yeah, I'm reading a book right now on the microbiome. It's called, anyways, doesn't matter. But yeah, and they're also, I have to read more about it, but they're talking about, you know, the sleep affects the microbiome in the gut as well, and disrupts it, you know, if you're having poor sleep. So that makes sense. And the microbiome is needed for, you know, keeping the bad stuff in our intestines and not coming into our bodies, essentially, kind of creating that barrier. And if we're disrupting the microbiome again and again, apparently with poor sleep as well, then that can cause like leaky gut and IBS and so on.
Yeah, there's just another like condition to our bucket. Like we're just going to be out here collecting. There should be mandatory sleep screening everywhere, if you ask me. Like,
yeah,
depression, like before you even like step into a therapist's office or a psychiatrist's office, like you should just go and you should get a sleep study and see what it says. You know?
Yeah, agreed. And it would be great if these companies that are doing these, you know, sleep tracking devices, like the one that you just stick on your chin, it's so easy. I mean, and it's pretty accurate. I mean, yeah, I wonder if we could make something like that available enough to people that, you know, could be so quick and painless, and they could have an immediate answer the next day.
That would be huge. Yeah, because in labs are so expensive. They're poorly scored right now. It's hard to get in. If you could just send somebody a sunrise home sleep study or whatever you wanted to use, get it done in a night, that'd be a big step for treating people. So
Yeah. Well, is there anything that we haven't talked about and that we should, or should we start wrapping up? And also, you said you were working on a website. Maybe we can, chat about that briefly and when you think it will be live.
Totally. Yes. So we're making a patient support site, and I think it's been a long time coming. I see people talking about it every now and then in the forums, like, oh, we should make a website. And so my friend and I, who also is UARS, and he's actually based in Germany too. So he's a web programmer, and he said, let's sit down, let's make this site together. And it can include our patient online spaces. It can include tools and services that people are using. And it can just be hopefully one more way that we catch patients. If people are Googling stuff like sleep apnea, or hopefully it would come up and we'd be able to get more traffic there too. So it's not quite done yet. We're still in the development phase, but I think in the next month or so, it should be up and running. And so,
cool.
Yeah, maybe we'll be able to post our open letter on there and get some, interaction that way. So.
Right. Oh, that's great. And people can go on the website and see the tools and so on. And also there'll be a provider search function, you said?
Yes. So one of our biggest hopes is to get a map of providers, because one thing I see again and again is people coming into the Reddit spaces and the Discord spaces, and they're like, who should I see? I'm based in this area. I don't really know who's good and who's not. I went to 5 doctors already and they were all bad. Only so many UARS providers that are good. And so if we could just have one centralized map, like a Google Map function, where people can input oh, I went to this doctor and he treats UARS. Great, he's a pin on the map. And now everybody can see it, everybody can access it. And I think that'd be really huge for our community. So
yeah, right. Super helpful. And these are doctors and physicians that are aware of UARS, right? And sleep labs that score RERAs and so on, right?
Yeah. Ideally, UARS aware doctors, there's only a handful, but or people like Anil Rama, he's amazing. I think we're lucky that he exists, but I think part of the reason he's able to do what he does is he's private practice. So he's left the bureaucracy and the insurance requirements, and he's just made his own practice. And he said, I'm going to do what I think is good for all these patients. But, as a result, he's a little more out there, a little more expensive, but super key. And he's not treating people with CPAPs, but he's got a million other things that he can do, like rhinomanometry, for example, or refer you to a lab that could. Actually, no, he does do sleep tests. He does sleep tests. I don't know if he prescribes or not.
Yeah.
So.
Yeah, he just seems like one of those doctors who's really on the cutting edge of things, and is just trying everything he can to help patients, and experimenting with, and just trying different things. And we're really aware of just flow limitations and RERAs and everything. Why is that so rare? Well,
RERAs.
Yeah. Well, maybe once the AASM is reformed, and more, if Medicaid, Medicare were to accept, the different, the 1A scoring, then other private insurers would follow suit. Doctors would be more incentivized to do this, and the structures would be there. I guess this would be a generational issue. It's not like the doctors who exist now are going to take a bunch of time off their, busy schedules to train themselves up on UARS. I think that's not going to happen, right? It's almost like, do we have to just hope for the next generation of doctors who's be better at it. And but then still, if we're classifying UARS as a subcategory or a less severe, quote unquote, version of OSA, which it's not, then that will make it difficult again for the doctors who are going through training to understand. I mean, it took us years to figure this out, and we're affected by it. I mean, having some sympathy for the doctors as well. It's like, it's if the training materials aren't there, how are they going to do it?
Right. Yeah, I think it starts with changing the curriculum in the medical schools. Like, if we're not teaching these doctors what needs to be taught, nobody's going to implement that in practice. And so we've got to teach our doctors about, I mean, I think even a step before that, it's so controversial right now that we need to create some new scoring standards, and we need to open up the ICSD-3 definitions and come to some kind of consensus about that and have a discussion about it. And then once we're able to do that, like, then we need to start educating doctors around the country, because sleep medicine right now, it's in the Stone Ages, but it's time for a change. So
yeah, crazy, right? Wow. I mean, it's cool that like a coalition of people are coming together, and there's obviously other awesome doctors, like, the one you're with, Dr. Nuaz and others are pretty amazing, but it's just such few numbers, I guess. Yeah. But they're the people with like huge voices too, right? So you would think that would have quite an effect.
Yeah, it seems like there have been quite a few researchers for a while publishing like on the scoring standards that need to change, but I think it's just been slow work. I think that the scoring committee has their own like set of what needs to be validated before they can incorporate it into each iteration of the manual, and it's probably scary for them to implement something based off of research that they're not very familiar with. But my hope is that this letter will really acquaint them with it and just, really give them a good rundown. Like, this is what the research is showing, and we are the patients that are showing there's a real public burden here.
Yeah.
So, yeah.
Wow. Yeah, that's a really good point, because the people on the boards are also just people, and they are familiar with what they're familiar with. And right, by you writing this letter and just drawing it out for them, you're educating them to make better decisions, basically.
That's the hope. Yeah, that's the hope. And we're obviously going to be into a discussion, like hopefully a dialogue, hopefully if they want to interact with us and talk with us about what we're asking and we can clarify stuff, I think that would be ideal, to just have this letter be the start of a conversation between clinicians and our patient group, because there are thousands of us, and we need more help, and we need more support.
Right.
Yeah.
Are you starting a petition at all, or?
Yes. Yeah. So I've started like a patient survey. That's kind of to show, like, I'm hoping to get as many UARS patients involved as possible. It's like a 5 or 10 minute survey that just kind of asks people about their experience within the field of sleep medicine and how hard it's been to get diagnosed. And then at the end, I ask if they would support a movement to change the scoring standards of the AASM. And I'm hoping we can get like a lot of people involved. So maybe I could even like link that survey on here or something. But
absolutely, yeah. Let's do that. So anybody who hears this, let us know, and we'll link that here in the show notes. And tell us how else they can reach you or help you in what you're doing, if at all. Yeah,
absolutely. Yeah, we've got an email set up. It'll be UARS.initiative @gmail.com. So you can put that in the link below too. And so, yeah, we're trying to just really be a good like hub for UARS, because I think our patient group is growing and we don't really have a system yet to support everyone, but I hope this is like the start of that. So
Yeah, it will be. It will be for sure. And there's lots of us, and yeah. So okay, we'll link that all, and we'll let everybody know when your website is up, and this video will be on this YouTube, and as well as I believe you have a channel coming up. So
oh yeah, would love to post that on my channel too. So
great. And I have a question to the viewers. If anybody knows how I can get a watch pad for research purposes, please let me know.
okay.
Yes, I really want a watch pad to be that guy who tests all his friends who have either ADHD, slight symptoms of depression, or anything else. I want to be that guy who's like,
yeah,
you know,
yeah.
my dream of a study is to really figure out what is the prevalence of this damn thing that we call UARS. Like, and like, how many of my friends are actually. I know that seems kind of ridiculous, and I'm again, that guy, but I do see patterns in certain people where I urge them to get a sleep lab, and they almost think it's kind of ridiculous to even consider going to a sleep lab because it's not a sleep issue they're dealing with. But meanwhile, I see they have bags around their eyes, complain of sleep a lot. They have a slightly protrusive jaw or small nose. All the things that I've been trained to think about over years, I see. And then, but it's funny that even the people themselves who are affected don't see that, because why would they? And that was me, right? Like 10 years ago. So
Right.
it's almost, yeah. So it's like to do research, but also to help my friends, basically.
That would be super cool. Yeah, it's definitely a spectrum, and us more severe patients are the change bringers, but hopefully we can look out for the people that are at the beginning of their spectrum too. So yeah, it'd be super cool.
Yeah. All right. Well, thanks so much, Colette. Really appreciate taking the time. Yeah.
Yeah, thanks for having me on. This was such a cool discussion. So hopefully we can have it in the future.
It was super fun. Exactly. We'll do it again, and take it up another topic for sure, and update on things. So
awesome. Okay.
Cool.